welcome to the Medicine Matters Diabetes podcast. I'm Eleanor McDermott. For this instalment of our series marking the 25th anniversary of the EASD's Psychosocial Aspects of Diabetes Study Group, I'm speaking again to Professor Bill Polonsky from the University of California at San Diego. This time we're looking at a long-standing but notoriously intractable problem, that of people not engaging with their diabetes. I wanted to talk about this because it just seems to come up constantly every time I'm talking to someone about, say, diabetes technology or preventing complications or whatever. The subject of disengagement comes up, and my impression is that at the moment it's a sort of big problem with just no answers at all.
It's the big problem we don't really talk about.
But presumably it's always been a problem. So why is there so sort of little knowledge on it, so little research done on it?
I think there's one really obvious reason, which is it's probably the hardest thing to research, because what you're trying to do is you're trying to evaluate, understand, interview the very group of people who probably are the least interested in speaking to you.
So when we're talking about disengagement, I guess there's a sort of big range that we're talking about, from people who just don't show up to people who, maybe it's an issue with just in certain situations. What are you looking at here, just to kind of define the range?
Well, even the definition is a challenge, and I think that's probably is the most important question. I mean, as I think about it, when we talk about someone who's disengaged, most broadly, it's someone for whom treatment of their diabetes is far from being a priority. And the reasons for that can vary quite dramatically. And the degree to which where it is on one's priority scale can also range quite a bit. So it can range from people for whom I'll get around to it when I have time, I'll put some effort into this, but I've got other things to worry about, versus other people for whom this disease doesn't really even exist for me. I'm not too sure I believe what I've been told by my healthcare providers, so I will just ignore it. And unfortunately, as we know, especially if we're talking about type 2 diabetes, especially in its early stages, it is a really, really easy disease to ignore.
So what do we know about these people at the moment? Do they have any sort of defining characteristics apart from the disengagement?
I think the answer to that is something, unfortunately, I'm going to say to you a lot, which is, I don't know, and we don't know. I think when we consider this broad category of people for whom we've never studied, we can think about a variety of possible issues that are going on. One is, I think the most important one is, again, this idea that it is simply not a priority. They have other important issues in their lives which are more important. Like, I have to make sure I can feed my kids, or I don't lose my job, or I don't lose my home. And so this relatively invisible disease, which isn't harming me today, can be put on the back burner, and I'll worry about it in some future time. There are people for whom disengagement might also reflect more of a personal struggle. People who might have very high levels of diabetes distress, who are very fearful about what uncontrolled diabetes might do or might cause them in the future. So it's better that I just don't even think about it. Again, it's kind of hard to know, but I would certainly argue and guess that really the vast majority of people who are disengaged are simply people for whom it's not a priority. It doesn't even mean they haven't been informed. It's just they have too many other things that are pressing. And I say that because I want to make sure, as we talk about people who are disengaged, we don't want to pathologize them, and we don't want to blame them. We just want to understand what's going on.
And what do we know about what's going on at a psychological level?
Nothing.
What do you suspect is going on?
I suspect at a psychological level, it has to do not only with how overwhelmed people are by other priorities in their lives, but what they know about diabetes, how engaged they are with a healthcare provider for any reason, what they understand and have learned about how diabetes might harm them, and also the degree to which they have ever been given any hope that, but with relatively small and simple actions, they can avoid all that potential harm. I think there's also likely to be, I guess I want to call it personality differences. I mean, we know from the field of, I guess it's most popular, the field of behavioral economics, that we know that people differ in the degree to which they are what we call delay discounters. So the degree to which they are willing to invest in their future or willing to prioritize, what sort of incentives or payoffs are more immediate than long term. And the whole field of what's called hyperbolic discounting or delay discounting, there's been a fair amount of work understanding about how, number one, we simply as human beings generally tend to value short-term incentives over long-term incentives. But we also know that's different from person to person. And we know that in our own families, people who are more likely to invest in their future in terms of savings, and those who are more willy-nilly and will take it just day by day and we'll see what happens and not worry about the future. So those differences are important and probably play a big role. Doesn't mean we can't do something about it, but certainly I'd suspect that's one of the bigger issues.
Do you know what sort of proportion of people we're looking at here who are disengaged?
My goodness, that's a good question. I only fear that it's huge. And if I had to guess, I would say it might even be the majority of people with type 2 diabetes, at least in my country, possibly in yours as well. But it's really hard to know. I mean, the reason we say that is that we know that the vast majority of people with diabetes, and again, I'm going to focus on type 2 diabetes, are not in a safe place, metabolically speaking, in terms of glycemic control, blood pressure, lipid levels, etc. We can blame that on a variety of factors, including our fragmented healthcare system. But again, it's the degree to which it's simply not critical for folks. And again, that is reasonable. There's just too many people for whom there's bigger things to worry about, especially nowadays when we talk about COVID-19 and the like.
And presumably people can kind of, come in and out of engagement and disengagement.
Sure. I mean, we know oftentimes diabetes does become more of a priority and people engage with it when a variety of different things might happen. Some of those are scary things, right? So someone has developed some long-term complication from the disease. All of a sudden, diabetes becomes real and diabetes care becomes more of a personal day-to-day priority for that individual. For some people, it's being told it's time to go on an injectable medication like insulin. And again, it's this sense of, oh my goodness, now I'm dealing with more serious disease. We've done some very early studies looking at what we call the something click phenomena, how other things can happen to folks in their lives. Oftentimes it's personal relationships, meeting a new healthcare provider who seems to care about them, other ways of learning or thinking about diabetes differently, that again causes diabetes to be perceived as more of an issue. It's, again, I want to highlight how much I'm simply just musing and how little we really know. As you know, I've done a lot of work with my colleagues looking at diabetes-related emotional distress. And one of the things that we have on our books, and we have certainly the data to look at, but we have not yet done, is that we know there's a quite large number of people who on our measures of diabetes distress score at the lowest level possible. And we are fairly certain those are not all people who are just doing great. Their lack of any kind of distress about their diabetes for so many of those people is a bad sign, and a sign, again, that diabetes isn't problematic for them because they are so disengaged from it.
Okay, so to summarise so far, it's a problem that affects potentially the majority of people with diabetes, but we don't actually know anything about them, and you can only speculate about why they are the way they are.
Unfortunately, that's true as so far. I do think there are avenues for research, as I've already mentioned a little bit, but it's difficult. Yeah. These are not the people who volunteer for studies.
So can you expand on what you think the potential avenues for research are?
Well, number one, like I just mentioned, it's going back into our own data and looking at across all of our studies, all of those people who've scored at the lowest level possible on our diabetes distress measures, and looking more carefully at who they are, how they're doing in terms of their cardiometabolic control, and what else we know about them. There has been some efforts with some of my colleague, headed by Dr. Danielle Hessler at UCSF, who's also starting to look at what we might think of as how activated the individual might be in their diabetes care, which is a way of slowly trying to get at that. There are researchers in both of our countries who have taken advantage of a measure developed many years ago called the patient activation measure. Again, trying to get at this idea of to what degree is someone, quote unquote, activated to manage their health, to manage their diabetes, or not activated. I'm not perfectly comfortable with that line of research, but the evidence in terms of what's been collected so far is solid. So there's been some efforts to understand this phenomena from a different way. Again, this idea of what's called patient activation. It's not quite the same, but it's trying to look at this again unknown phenomena that we just know is so big out there. I guess I could think about, as you asked me about research, one other example of where we might look is when we think about the field of diabetes education. We know of the, first of all, the people who develop diabetes, and again, we'll stick with type 2 diabetes, who are referred for diabetes education. Very, very, very few of them ever actually attend any kind of program at all. If I remember correctly, I think the best data is actually from the UK, where again, the numbers are in the single digits in terms of the percentage who actually ever make it to a program. So that may represent a group for whom they are, again, if not disengaged, the idea of taking action for their diabetes is not a priority. Of course, that's may be mixed with the fact that they may simply perceive that an education program is not what they need at that time or not important. Related to that, we also know, and again, the evidence is not as strong as I'd like, but that even people who do attend a diabetes education program, if it is a multi-session program, a very large number of those people never complete those programs. They'll drop out very quickly. And again, I want to be careful not to blame people for that. They may be dropping out not because they have lost their motivation or disengaged, but they're simply bored and don't find those programs that are personally touching them in some way that's meaningful for them. Again, the study in this area is fairly limited, but these are other areas in which we've been talking about and thinking about wanting to look at more carefully to try to understand what kind of populations are out there, how big are they, what's going on with folks who are, for whom, again, I'm hesitant even to continue using the word disengaged, just for whom the idea of putting out day-to-day effort to manage one's diabetes is in any way a priority.
If you have a person with diabetes who is struggling to be engaged, maybe not totally disengaged, but there are issues in that area, is there anything that's known to be effective that healthcare providers can actually do to help them?
Well, I'm really glad you brought that subject up. Once there is, I really appreciate the word struggling. We know once we're talking to someone for whom there's any interest in managing their diabetes, we really know exactly what we need to do. One of the things that we are, I think, focus on in all of our efforts is we say it over and over again. Nobody's unmotivated to want to live a long and healthy life. Nobody. And so once any of us have the chance to sit and talk with someone for whom we can identify they have some interest in that, especially some interest in perhaps making sure that diabetes doesn't harm them in the long run, we have the kernel of intervention there. Again, we then target someone's ambivalence. Yes, I understand that this disease or making effort to manage this disease is not a priority, but I also know you're interested in living a long and healthy life. So can we think about some simple and easy things that might be worthwhile for you to do, that are minimally invasive, minimal hassle, but can also pay off for you in the long run? So yeah, once we're dealing with someone who is showing me some shred of ambivalence, that I know I can target that. And I would tell you, I think that's literally anybody we will meet in person. Anybody. When I worry about the disengaged population, it's those people for whom I'll never meet and have no interest in ever talking to me, or perhaps will never talk to a physician. I may have mentioned to you this once long ago that years ago, I had a publisher who came to me and several of our colleagues and said, we would like you guys to write a book for us. And I absolutely loved this idea. And the title of the book was to be called Diabetes for the Disengaged. And we threw ourselves into this project and said, this is going to be wonderful. It's something I've always wanted to do. And as we began to outline and prepare this book, I suddenly had a thought, and I went back to the publisher and I said, unfortunately, by definition, the book you want us to write is designed for the people who will never read it. And the publisher went, oh yeah, I guess maybe we should cancel this book idea. But it is at core our challenge, right? So I don't quite yet know how to talk to someone who doesn't really have any interest in talking to me. It's why we have national campaigns. One of the things I've been thinking about is, what are we going to learn from COVID-19? I mean, very similarly, we're dealing with a disease that's invisible until it's not. The timeline is different. It's much shorter. We know we're dealing with the same issue across many of the chronic illnesses in our societies, whether we're talking about, hypertension or, high lipid levels or, risk for cardiovascular disease in general. We're dealing with diseases that are relatively invisible until they're not. And so the potential for disengagement, or for saying, I'll worry about it when something hits, I'll worry about it when something falls off, I'll worry about when I have a heart attack, then maybe we can talk about this, is our biggest frustration. Again, I feel like I don't have too many solutions to this right now, but it's nice to talk with you about it, because it should become and must become a priority for us to begin to try to find better ways of addressing this. As a researcher, it is an extraordinarily important and fascinating area of work. I think it's an area in which I think we're going to have the greatest benefit moving forward in the future, as we really engage ourselves to think about this and can develop understanding and interventions. And it's for now and for the future for us to apply ourselves.
Thank you to Bill. And thank you for listening to this podcast, produced by MedWire News for Medicine Matters Diabetes. Please subscribe for more, and don't forget to visit diabetes.medicinematters.com for news, expert opinion and practical advice about caring for people with diabetes.